Hello, my name is Kathy Huey. I'm partial owner and manager of Brain Huey Pharmacy in North Wilkesboro, North Carolina, and I've been working as a pharmacist for 20 years. Through Project Lazarus, I've developed a passion for the education of pharmacists, patients, and caregivers on the opioid crisis that's affected our state. At the conclusion of this video, my hope is that you will feel more comfortable assessing risk, providing counseling and education, and ensuring patient safety, and will leave with a renewed sense of purpose and understanding for the important role that you play as leaders in preventing the misuse and potential overdose of opioid medications. To begin, let's start with some important facts about the standing order. The North Carolina statewide standing order for naloxone was signed into law on June 20th, 2016, and authorizes all North Carolina licensed pharmacists to dispense naloxone to any person meeting criteria, and it covers all North Carolina residents to either request naloxone for themselves or others. Try not to be misled by advertising suggesting that naloxone is available without a prescription. As dispensers, the standing order is your prescription, and the prescriber is the acting state health director. If you're not familiar with the website, www.naloxonesaves.org, consider saving it to your favorites list for all things naloxone. It's the companion site to the statewide standing order and contains education for both pharmacists and the public about naloxone. Located under the General Information section, you find a signed copy of the state standing order. The Naloxone User Survey link is where you direct patients if they use their naloxone. Pharmacists should direct all patients receiving naloxone to the user survey as part of their routine counseling. Some community pharmacists have found it easiest to actually print the homepage and provide it along with the patient's prescriptions. To dispel any angst patients may have regarding their use, assure them that all responses are anonymous and used solely to help better understand how we can continue to provide naloxone to the people in greatest need. The naloxone prescriber link houses the pharmacists participating in the statewide standing order and provides a resource for prescribers to refer patients. If your pharmacy is an active dispenser of naloxone per the standing order, make sure you register your participation on the site. It's optional, but it serves as a great marketing tool and is free advertising. Elements of the standing order can be found down the left-hand column and include eligible candidates, formulations, directions for use, refills, contraindication, patient education. The content within each element is pretty straightforward. I'd like to concentrate on the use of the word voluntary request, found in the eligible candidates section. It's mentioned several times and is very terminology that contributes to the most common misconception among pharmacists today. The standing order states only a person in need, family member, or friend can request naloxone. The phrase voluntary request was merely meant to deter rote dispensing of naloxone. It was never intended to lessen the value that pharmacists play in determining patients at risk. In fact, it's quite the contrary. Pharmacists are in the best position to make these determinations, and as mentioned earlier, I hope you'll embrace the leadership pharmacists can provide in promoting these life-saving medications. As a pharmacist, to all pharmacists, I challenge you to screen your patients. If you believe your patient's at risk for overdose, don't wait. Initiate a conversation. If a patient agrees to naloxone after the assessment and counseling, it's the same thing as the patient making a voluntary request per the standing order. There are some that would argue offering naloxone to all patients with an opioid prescription and allowing them to opt out is the best practice over an opt-in approach. In fact, an opt-out approach where pharmacists provide counseling with all opioid prescriptions would actually help destigmatize the issue, since you're including all recipients in the conversation and not just a select few. You may be asking yourself, how do you screen? For starters, make sure you know the high-risk patients outlined in the standing order. For instance, patients with a prior history of substance abuse, including alcohol, those coming from detox, mandatory abstinence program, or those patients enrolled in prescription lock-in programs. Some of the highest risk patients are those with a prior history of overdose. In 2015, a study in the Annals of Internal Medicine looked at opioid prescribing after non-fatal overdose and concluded that 91% of patients continued opioids from their same prescriber after their overdose, with 49 of these overdosing again within 2 years. Pretty strong evidence for naloxone, don't you think? If you couple this with the fact that very few hospitals even offer naloxone at discharge, it speaks volumes to the role community pharmacists can play in filling this void. Other candidates include those with conditions that make them more susceptible to the effects of opioids, like patients with respiratory, cardiac, renal, and hepatic disease, as well as HIV or AIDS. Also included is any person presenting with an opioid prescription written for more than 15 morphine milligram equivalents per day. This risk comes from the CDC suggesting doses above this increase overdose risk without necessarily adding benefit to pain control or function. In addition to the standing order list of naloxone candidates, consider these. An individual on benzodiazepines. Benzos in combination with opioids are associated with a near quadrupling effect of overdose compared to those on the opioid alone. In 2016, data from the North Carolina Controlled Substance Reporting System reported a 10-fold increase in overdose deaths from this combination. As pharmacists, you may be the first to pick up on patients using both agents. Best practice is to avoid the combination altogether. Even prior to counseling, consider contacting the prescriber or prescribers to discuss alternate therapies. Think about persons using multiple pharmacies and providers. Both may represent a form of aberrant behavior, often predicative of substance misuse disorder. The best way to evaluate whether an individual is using multiple pharmacies or providers is to, of course, check the Controlled Substance Reporting System, or the CSRS. Consider ways you might incorporate the CSRS reporting system into your daily workflow. For example, having front-end or technical staff triage incoming opioid prescriptions and printing a report using the CSRS delegate account for any new opioid prescriptions presented for filling. Medicaid recipients have also been found to be higher risk for overdose. One analysis showed that Medicaid recipients represent 20% of all the general population prescribed opioids, but account for 33% of overdose deaths. There is a similar disparity among patients treated with methadone. In cases where methadone was prescribed for pain, it was responsible for a third of all opioid-related overdoses involving a single or multiple drugs, despite the fact that it represents less than 2% of opioid prescribing. Lastly, opioid injection is the leading cause of ED use and hospitalization in children. Even if you determine that your patient isn't at risk, don't forget to inquire about others that may be in the household, especially children and teenagers. Make sure to counsel a patient to store their medication in a locked cabinet, a lockbox, or a location where others can't easily access it. Safety caps do not keep children or teenagers out of medicine bottles. Prevention can go a long way. With regards to starting the conversation, a study published in the Journal of the American Pharmacists Association presented scenarios based on offering naloxone to 8 focus groups, which included illicit drug users, chronic opioid patients, caregivers, family members, and pharmacists. Interestingly, researchers found that all groups reported stigmas associated with offering naloxone. Pharmacists reported a lack of training, access to demonstration materials, and time constraints as practical concerns. But more importantly, pharmacists worried that by offering naloxone, they would offend their chronic pain patients or undermine a patient's care plan. Similarly, illicit drug users and chronic pain patients, caregivers, and family members reported feeling uncomfortable requesting naloxone for fear of being labeled or treated differently. So, how do we move past these barriers and have meaningful conversations with a patient without the stigma? One way is to avoid using the word overdose. It's hard to do when our conversation needs to focus on preventing overdose, but the word, more times than not, has negative meanings to our patients. For instance, take the grandmother who uses opioids under a doctor's supervision. They underestimate the risks simply based on the belief that because their doctor prescribed the medication, it's not harmful. In this situation, overdose may cause anxiety or even scare the patient. Or how about the patient filling an opioid for the first time? Their interpretation of overdose may sound offensive, as if you're suggesting that they're an addict or a drug abuser. Consider some of these conversation starters to help you avoid the overdose trap. Opioids can cause bad reactions that make your breathing slow or even stop. This can happen if your body can't handle the opioids that you take, or if you take an opioid with alcohol or other drugs. Naloxone is a lifesaver, just like a seatbelt or a fire extinguisher. These medications can be helpful, but have a range of side effects like slowing down or even stopping breathing completely. Naloxone can help if it happens by restoring breathing, or maybe opioid medications increase the risk of breathing emergency for the person who takes the opioid. Naloxone is in case of an emergency. Let's keep you and your family as healthy as possible with these medications in your home. Just in case, get naloxone. To wrap things up, let's walk through what a counseling session might look like. Start with an explanation of your counseling. Something like, you may have heard about the opioid epidemic and how it's been responsible for a number of deaths in our country and our community. To ensure our patients' safety, we're providing counseling to all patients who feel an opioid medicine. Would it be okay with you if I took a few minutes to share some information about your medicine, using naloxone, and how you can best secure your medications before you leave? Always ask patient permission. This establishes buy-in. Discuss appropriate storage of the opioid. Say something like, to ensure not only your safety, but the safety of others in your home or those who may visit your home, like children, teenagers, the elderly, or even pets, it's important that you store all your medications in a locked cabinet, locked box, or a location where others can't easily access them. Address risk associated with using the opioid using your conversation starters. Opioids can cause bad reactions that make your breathing slow or even stop. This can happen if your body can't handle the opioid or if you take the opioid with other drugs or alcohol. Address why naloxone is a smart choice and include the patient's risk factors in your discussion. Naloxone can reverse the bad reaction caused by opioids and save your life. Based on reviewing your medications and knowing that you have COPD and breathing is already difficult, naloxone can be a good medicine to have around in case of an emergency. It comes in a variety of forms, and we can choose the one that best works for you. Think of having an EpiPen if you're allergic to bees, or a first aid kit or a fire extinguisher. If the patient agrees, choose a product, demonstrate its use, and have the patient teach back administration. If the patient is the recipient of a naloxone, make sure they identify a partner to give the naloxone in case of an opioid emergency. If you have an opioid emergency, you're not going to be able to give yourself naloxone, so it's important that you identify someone who can administer it for you. Confirm that they're going to discuss with their partner the signs of an opioid emergency and when to give the naloxone, or offer counseling yourself via a phone. Signs of an opioid emergency to know and to make sure your partner know includes extreme drowsiness or unresponsiveness. Breathing may be slow, shallow, or absent altogether. Pupils may appear very small or pinpoint. The pulse may be slow or undetectable, and fingernails and lips may appear blue or purple in color. You only want to give naloxone if you can't wake someone with a loud noise or by rubbing hard on the middle of their chest, or if breathing is slow or they look like they're not breathing. Confirm that they'll discuss with their partner where the naloxone is to be stored so that it's easily accessible in the event of an opioid emergency. And remind them that naloxone's effect is short and they should call 911 immediately after giving the dose. With the information shared here today, my hope is that you will now feel more comfortable and confident in the role that you can play in combating the misuse and potential overdose of opioid medications.